Hello, my name is Professor Jeff Bamber. I'm here on behalf of IBUS. I work at the Institute of Cancer Research and the Royal Marsden Hospital, and we're here to give a demonstration of the physics and optimization of ultrasound scanning. This demonstration is meant to complement the IBUS lecture on that subject. And the idea is to provide some illustrations of selected points from the lecture, which is to illustrate particular functions on the ultrasound scanner, and also to give examples of how when you change the controls for those functions, what effect that has on the image appearance. And so by the end of watching this demo, you should be able to, at least at a basic level, set up the ultrasound scanner for getting the best images for the task that you have in front of you. So the first thing that you may remember from the physics lecture is that there is a strong acoustic impedance mismatch between, and I'm holding an ultrasound probe in front of me, between the material of the ultrasound probe, the piezoelectric that emits the ultrasound, and air. And if we are holding a transducer in the air, then what you're getting mostly on the image, which I'm pointing to now, is a reverberation of the sound within the piezoelectric and within the rubber lens on the end of the probe. And very little sound is propagating out into the air, and so we see these reverberations. Because of that strong acoustic impedance mismatch, we need to put ultrasound gel to couple the probe to the skin. If I place the probe on my own skin, and you can see on the scanner, if I unfreeze, you can barely see any image at all. My skin is fairly dry, and so therefore there's no way of coupling the sound into the tissue. We must put some coupling medium on the probe, and I'll do that just straight, put some gel. Immediately I do that, you can see the sound bouncing around between the probe surface and the gel air interface, and you can see all these reverberations. But as soon as I put the probe on my skin, immediately you can see an image of my thyroid gland, jugular vein and carotid artery and neck muscles. So that explains in a way that's related to the lecture why we need the gel. So the next thing I want to remind you of is the need to select the appropriate transducer. And although there are some different types of transducers, for example the linear array and the curvilinear array, for breast imaging, of course, you'll mostly be using linear arrays. This sort of array is useful for abdominal imaging, obstetrics, and so on, and is needed in order to obtain, with this small aperture that is the acoustic window on the body, a wide field of view at great depth. And it's useful for that, but not particularly useful for breast imaging. So putting that one aside, we have two different linear array probes here. This 9L and this ML615. This 9L is a nominal 9 megahertz linear array, fairly short. This one is a little bit longer, gives you a slightly wider field of view for breast imaging, but also in the elevation direction, this is a single row of elements, whereas this is a 1.5D array, and that has 5 rows of elements and will give you extra resolution and in the elevation direction, in other words, a smaller slice thickness. So this would give you much better resolution, but also better penetration and better, what shall I say, contrast, particularly with regard to discriminating whether they're echoes within, for example, cystic structures, where with this probe there'd be more chance of echo fill-in and difficulty of discriminating whether something is a cyst or not. So this is a good probe to use for breast imaging. But nevertheless, both probes give good high quality images. The point that I want to demonstrate to you here, I'll use both probes in fact to demonstrate this point, is the selection of the frequency within each probe. Each of these probes has very wide bandwidth, and you can select the frequency that you want to use. That selection of frequency, and also if you had even higher frequency probes present, or lower frequency linear arrays, the selection of the probe or the frequency you're going to use within a particular probe is based on that fundamental compromise that I explained in the lecture. And that is that you choose a low frequency if you need to penetrate to deeper tissues, and a higher frequency if you don't need to penetrate to deeper tissues. And the reason for those selections is that if at all possible, you choose the highest frequency that you can so that you can get the best spatial resolution. The reason for all of that is that you will see in the physics lecture that the attenuation of sound is increasing with frequency all the time. We'd prefer to use the highest possible frequencies because they give us the smallest wavelengths and therefore the best resolution in the images. So always go for the highest frequency that you can find for the depth to which you wish to penetrate. So we'll put some gel on the probe, and I'm going to image a phantom, which is actually a physicist quality control phantom, but it works pretty well for illustrating this. And you can see on the screen what we're looking at right now is some cylindrical insertions that look a little bit like tumors of different contrast of brightness to background. And in here are also some wire targets that in this plane look like points. And the size of these for a physicist who's making measurements of the quality of the ultrasound scanner, he would be looking at the size of these points as they're displayed as a measure of spatial resolution. And a measure of contrast discrimination is provided by these targets. You don't need to know that, but that's the sort of phantom that I'm working with. Now, I'll just go to a slightly larger depth setting so that we can see the full depth of the scan, and show you what the effect of changing the frequency is. At the moment, I've set the scanner to a very low frequency, 5 megahertz. That's not typical of what you use typically for breast imaging. We would go for a higher frequency usually because we don't need this large penetration depth in general. I mean, this is at the moment penetrating all the way down to 10, 12 centimeters, it appears, in this phantom, which is tissue mimicking in its attenuation properties. So if I go to a high frequency and switch from 5, 5.5, you start to see the image changing. We're at 6 megahertz now, 7. You can see the speckle. We'll talk about speckle in a moment, but you can see these points of the point targets, the wire targets, sharpening up as we go to 9 megahertz, and that's the top frequency of this probe. So you can see the effect of that, the improved resolution and the reduced depth of penetration. Now we're only penetrating to about 7 centimeters at 9 megahertz. If I switch to the other transducer, you'll be able to see that. I can exaggerate even more because this one allows us to, we'll take a moment for the scanner to bring in this other transducer. And I'll need to increase the penetration depth on the display first, but what you can see there immediately is the effect of the better transducer in that these point targets are really beautifully displayed as very fine points now, and very nice tissue contrast between these cylindrical inclusions there in the background. Very sharp definition of the boundaries of these, so you can see the superiority of this probe, this 1.5D matrix array. At the moment, this is automatically setting itself to 15 megahertz, assuming that that's the frequency that we want to use because we switched to this transducer. And you can see the consequence of that is the penetration depth is not much better than, well, it's about 4 centimeters, very shallow. As I decrease the frequency, that's 12, and now 9, and that's the lowest frequency that this probe will go to. At 9 megahertz, that was in fact the top frequency of the previous probe. At 9 megahertz, we're now penetrating to about 5 centimeters, so a little bit of improvement in penetration depth, but quite a loss of spatial resolution. If you check that, we can switch back. That's 9 megahertz. Look at the sort of size of these points, and in fact, I could zoom in. Let's do that. Let's zoom into some of those points, and you should be able to see the effect of improving the point target resolution there as I increase the frequency to 15 megahertz, and that's the effect of it there. You can see the points that are displayed very tiny. The next thing I want to describe to you is, having chosen the probe that you're scanning with, and you now understand selection of the frequency to use, you now need to think about how to set the scanner controls for getting the best image. Now, the easy way is to let the scanner do it for you. On some scanners, there's a thing called auto-optimize. There are other names that different manufacturers provide to that control. And you can just press that button and the scanner will set itself up for you to provide a pretty good image. Equivalent to that is often if you select the application, such as breast, select the breast application. And then many scanners will set the controls optimized for breast imaging. But of course, optimum for one breast is not necessarily optimum for another breast. Optimum for one pathology that you want to look for is not necessarily optimum for another. Cystic solid differentiation is not necessarily going to be done with the same settings as you would, for example, looking for some of the diagnostic criteria to distinguish between benign and malignant solid masses. So understanding how to optimize the scanner is helpful. You can use the automatic optimization buttons, but I think you'll always do a little bit better if you know how to do it yourself. Now, I will come back at the end of the video with demonstration of the difference between setting things up yourself and setting it up with the auto-optimize button. For the moment, we're going to go through it, if you like, the hard way, and we're going to do it ourselves. So the first thing I want to talk about in terms of scanner control setup is gain and time gain compensation. Gain is fairly straightforward. That's the average brightness of the image, and that's how much the scanner is going to amplify the strength of the echoes before displaying that echo strength as brightness on the screen. The time gain compensation, also sometimes called depth gain compensation or swept gain on some systems, is set by these scanner sliders that you see here. The overall gain on this particular scanner is just a single knob that's there, which interacts with something called the acoustic power output that is over here on the scanner. We'll come to that one in a moment. But first of all, the interaction between gain, these TGC sliders, and one other thing, which is dynamic range. Now, dynamic range adjusts the relationship between small echoes and how much they're amplified before they're putting on green, and strong echoes and how much they are amplified before they are put on the screen. High dynamic range means that the low weak echoes are going to be amplified a lot relative to the strong echoes. This allows a very wide range of echo strengths to be put on the screen at once. But because of that wide range that is being put on the screen in terms of echo strength, the ability to discriminate one brightness from another, one echo strength from another, is poor. If you select a low dynamic range, that ability to discriminate different echo strengths by looking at the brightness on the screen is much better. I showed in the lecture the logarithmic graph that describes input echo strength against brightness on the screen. And from that graph you can sort of see what I'm trying to tell you right now. We'll actually show you that on the screen in terms of contrast that can be displayed on the screen. The reason for mentioning it now, because I'm talking about gain settings and time gain compensation settings, is to mention that if you're trying to set the TGC, then don't do it with the dynamic range control set at the maximum, because your sensitivity, your visual sensitivity to small changes in image brightness does not give you a good ability to discriminate between the different echo strengths, and therefore you would not be very sensitive to setting the TGC control. So let's have a look at an example of that. At the moment you can see that I've got the dynamic range set here to 96 decibels. That's the maximum on this particular scanner. And that means everything looks really quite grey, a bit washed out. And the brightness of the points and this strongly reflecting inclusion is not very different from the brightness of the background. Everything looks fairly similar. And indeed, if I change the brightness control, we see it does have an effect on the image brightness, but the rate at which I'm changing this control, you'll see in a moment when I set the dynamic range lower, the rate at which the brightness changes here is not as rapid as it would be if the dynamic range were further down. In particular, if I change the TGC sliders, you can see how there is an effect on the image with the TGC sliders, but it's not dramatic. And particularly if the dynamic range is high and the brightness control is high, you can see almost no change in the image as I move these sliders around. So that would be absolutely useless for being able to adjust the depth gain curve. If I turn the brightness down, on the other hand, and I turn the dynamic range down, and there is an interaction between these two controls, I'll turn the dynamic range down to the minimum it will go. This is an unreasonably low setting. You wouldn't normally use it this low, but the immediate impact on the image that you can see is this very contrasty appearance, and it's saturating now at the higher brightness levels, so we'll have to turn the brightness control down. One effect of having such a low dynamic range is that it's impossible to display all the information that you want to appear on the image simultaneously. You actually have to interact with the image, changing the brightness to be able to see a nice background speckle contrast, and then you'd turn the image down to see this brightest lesion clearly, and you'd turn it up a bit to see the lower level lesion. However, this sort of setting is really quite nice for getting the TGC just right, because it makes you very sensitive to small echo strength changes. So now you can see that the TGC is not set very well. These sliders are all set to be giving us constant gain with depth, and I can increase the gain at that particular depth, and you can see this bright band appearing across on the image there at that depth. That's obviously overcooking it at that stage. But what we can do is now set the image up so that we're getting really quite a nice, we need a bit more there, a bit down here, and we can get a reasonably homogeneous brightness with depth, as you can see there. Now I'm comfortable with that TGC setting, and with practice, my colleagues in the clinic to do this in a fraction of a second, just sliding their fingers across these controls, setting that up for a nice homogeneous image with depth, which is what you're aiming for. And then you can turn the gain up to the gain setting you desire, and the dynamic range up to the region you want. Where to set the dynamic range depends on what you're looking at the image for, what you're trying to discriminate. But a good typical sort of ballpark figure, I would say, is in the region of 70 decibels. The scanner either flicks between 69 or 72, and it also depends on the ambient viewing conditions. For the purposes of making this video, we actually have a spotlight in the room and high brightness in the room. You wouldn't normally scan, of course, in those lighting conditions, because it makes it more difficult to see very low contrast details on the screen. You would be scanning with a dimmed lighting conditions. But that can to some extent be compensated for by changing the dynamic range and reducing the dynamic range slightly in these sorts of lighting conditions gives us a more contrasty image and makes the image visually easy to see. But the consequence of that is that I have to be careful that I'm not missing something, and I would have to interact with the image by changing the brightness dynamically as I'm viewing it. So the next topic to discuss is briefly the interaction between depth setting and frame rate. Depending on the other settings of the scanner, this may or may not be particularly strong, but as you remember from the lecture, I hope you remember, is that the go and return time to the depth of interest, the maximum depth of interest for the ultrasound, combined with the speed of sound, is what determines the frame rate, as well as the line density, the number of lines that one's reconstructing in the image. So the line rate, the maximum line rate that the scanner can run at, is still determined by the go and return time, and therefore the speed of sound. So the point that I'm making is that if you insist on imaging to large depths, you will get a lower frame rate than if you image at shallower depths. That's not a strong effect on this particular scanner because of compromises in other areas that are made. But you can see here the frame rate is 61 frames per second for this particular probe and the settings that I've set up on the scanner. And then that is for imaging to a depth of about 12 centimeters. If I reduce the depth, one can immediately see we've gone up to 76 frames per second, illustrating the point I'm making. Those are very high frame rates. We don't need those sorts of frame rates for imaging the breast. The reason we're getting those frame rates here is because of the other settings that I've put into the scanner, and that is because I want to illustrate what some of the functions actually do. This image is actually currently set up to be a fairly poor image. It's a sort of old-fashioned image, the sort of image that we would have been observing routinely if we've been scanning with an ultrasound scanner that had been built, say, in about 1985 or so. When things like speckle reduction and angle compounding and tissue harmonic imaging and all sorts of other clever techniques had not yet been invented, or if they had been invented, they'd not been incorporated into commercial ultrasound systems. Multiple focal zones is another one, and all of these things tend to slow the frame rate down a little bit. which I will gradually switch in one at a time to show you what the effect is on the image appearance. So let's start with image line density, and I will use, let's say, a depth of penetration to about 4 centimeters for this. You can see clearly this brightest inclusion. You can see the speckle in the background, and at a frame rate of 76 frames per second. This is running at a minimum line density. It doesn't actually tell us what the line density is in lines per centimeter, but if I gradually, in fact what I will do is I'll put it to the maximum line density, and hopefully the resolution on the video is good enough to be able to see on this image that the points have sharpened up, but in particular you can see the speckle in the background really sharpening there. Probably the best way of showing that is if I zoom in, and I can do that on the ultrasound scanner, but what I want to just draw your attention to is what's happened to the frame rate. It's now dropped from 76 all the way down to 25 frames per second. So there was a big penalty in improving the image in this way. Again though, for breast imaging, who's worried? 25 frames per second is perfectly adequate for surveying the breast. It's not like echocardiology where we need really fast frame rates. So I would always put in the line density if I was setting the system. I would set that to maximum. Let's zoom in, as I said I would, and illustrate that effect of that line density by looking in detail at this speckle pattern. You can see here this fine speckle, and we're going to, as I said earlier, going to talk about what speckle really is in a moment. And now I'll gradually put that line density down to 0. That's 0 as a setting on the controls. It's not 0 line density, obviously. And this line density, you can see that the image is being reconstructed to quite a coarse sampling. It's saving time, but it has a really severe penalty in terms of image quality. We're not really seeing the true physical speckle pattern there. It's undersampled. The scanner's done some nice smoothing to cosmetically improve that poor result, but it nevertheless still is a poor result. As I just change the probe angle a little bit, you can see shimmering and artifactual black spots and undersampling artifacts appearing in the speckle pattern, which indicate how bad an image that is. If I switch that up to the maximum line density again, you can now see the little wormy pattern of the speckle being clearly and faithfully reproduced. And even this point target is a little bit sharper with the higher line density. It's interesting, it's not actually changing the spatial resolution of the ultrasound beam. That still exists inside the medium we're imaging. We're just displaying it in an undersampled way if we use a low line density. That's line density. From now on, I'm going to leave that set at the maximum setting, because in my opinion, that's what we should be scanning with. Take the zoom control out, and we'll do one next thing in getting from these images to a gradually better and better image. You can see on the right a single sort of caret, as they call it, on graphical displays, indicated a depth at 2 centimeters. This is telling us that there is, because there's only one of these carets, a single focal transmit zone. On receive, all modern scanners have dynamic receive focusing, which I explained in the lecture, and that is not under user control. It's just running in the background automatically. But on transmit, we have a choice of how many transmit focal zones are switched in, and the reason we have a choice is that there's a penalty for that, whereas with dynamic receive focusing there is no penalty. And the penalty for transmit focusing is that the more transmit focal zones are switched in, the slower the frame rate. In fact, we divide the frame rate by the factor of the number of focal zones. So with one focal zone in, that factor is 1. And this means, though, that there is a slight degradation of system resolution outside of that focal depth. And you can see that manifesting itself by the fact that at this depth, these 2 point targets are well in focus. It's starting to get a little bit blurred as we go to these point targets that are nearer to the transducer, and also a bit blurred as we get deeper. If I go to much deeper depths, you can see these point targets are very blurred by comparison to those. So what happens if we switch in more focal zones? We can do that. Here's 2. We've not changed things down here very much. We've helped a little bit up here. One nice thing is we can adjust the position of the focal zones. So I can move those down to something deeper. And if I switch back to 1, you can now see, if I go change the depth setting and position the focal zone deeper, then at least that focal zone is giving us optimum lateral resolution at that depth at 5 centimeters at the moment. If I move that up to something much shallower, the best focal position is here. So if you really were worried about the frame rate, you can keep yourself to 1 focal zone and adjust the position, the depth of that focal zone, to be at the location of, say, the pathology that you want to image at the highest resolution and get the best detail for diagnosis. However, for breast imaging, the frame rate penalty that you get, which at the moment we're running at 25 frames per second for a single focal zone, if we switch in 2, that drops to 13 frames per second, still a reasonable frame rate for breast imaging. So let's go to 3 or even 4. Now we're down at 6 frames per second. If you're surveying the breast rapidly, you're likely to see a little sort of jerky motion in the image. And as I move the scanner probe around, you can see I'm moving around on the phantom, you can actually see that jerkiness in the image displayed on the screen. It wouldn't bother me, but it might bother some people. And you might say, well, we don't need 4 or 5 focal zones. I can still reposition those, but you can see the benefit in the image quality is that we're getting, particularly if I position them well, we're getting good resolution at all of the depths, pretty much all the way down to about 5 centimeters, and it's not too bad all the way down to 6. So that's the advantage of it, but down to 4 frames per second now. Very, very slow frame rate because of that. So some compromise is obviously necessary, and I would have said for scanning the breast, maybe 3 focal zones. 8 frames per second is not bad, but you might feel that jerkiness in the image as you're moving around is a bit distracting, so 2 focal zones might be reasonable. So we'll leave it at 2 focal zones for the moment, and then we'll switch in the next image improvement property. So that next image improvement property that I'll show you is speckle reduction for what on this scanner is, I think, called high definition imaging. Speckle reduction processing can occur in several different ways, and you can use all of them. The simplest thing to use is persistence or frame averaging. You'll see it as different labels on different scanners. And what that does is provide in real time a dynamic averaging of the images over time. So, and typically an exponential decay weighting function is used, but you don't really need to know that. That's just saying that in the temporal average image that's displayed, the emphasis is on the current image, and there's a gradual lesser weighting in the past images that are included in the temporal average. Now the effect of that temporal averaging, or persistence as it's sometimes called, is to average speckle from one frame to the next if the probe is moving. Now this point I really need to need to tell you what speckle is all about. We did talk about it in the physics lecture, but it's that interference between the echoes that come from different parts of the tissue structure that happen to be close enough to be within the pulse length and within the beam width. In other words, each point in the object has on the image a spread function. The physicists call this the point spread function. But if two tissue structures are closer together than that point spread function, then the point spread function from each of the tissue structures will overlap. And those two overlapping point spread functions can interfere with each other. That interference, the word interference, is like code word for physicists. It means that positive parts of the wave can add up when they coincide. So in that point spread function, the ultrasound waves have both positive and negative components, and if two point spread functions overlap just right so that two positive going parts of the two different waves interact, they will constructively sum up and give us a large amplitude. On the other hand, if a negative region sums up with a positive region, they could cancel and give a small amplitude or even zero, no signal at all. And the speckle pattern is a result of all that interference of waves coming back from ultrasound scatterers that are very, very close to each other. It's a unique phenomenon of coherent imaging systems, like radar, like underwater acoustics, like lasers, laser speckle. And it doesn't occur with other types of medical images in general. So let's have a look at the speckle. And I'm going to zoom in again to do that. And you can see that speckle. It's interesting, it's almost like noise. It doesn't actually relate to the real structure of this phantom because it's coming from structure that is actually too small to be resolved. So it's artifactual image detail, and it's interfering with our ability to see the real image detail. So we'd like to reduce it. It reduces low contrast discrimination, for example. So to improve that, we want to reduce the speckle. If I tap the phantom, you can see the speckle shimmering. And that's the basis for reducing the speckle using persistence. As I scan around, you can see the speckle pattern is changing. So if we switch in persistence, and I'll do that now, on this scanner it's called frame averaging, and I'll immediately switch it to maximum, and you can see now immediately the speckle is much reduced, but only so long as I'm moving the probe. Notice if I'm holding the probe stationary as I am now, the speckle is as clear as it ever was. But as long as I move, then we see some speckle reduction. And if I go back out of the zoom mode and just look at that low contrast image, I will reduce the depth of penetration a little bit so we can see that inclusion. You can see how the contrast between the inclusion or lesion and the background improves as the speckle is reduced while I'm moving the probe. Low contrast, probably easier to see if I go over to this part of the phantom, and you can see these two low contrast lesions, one positive, one negative, and as I move the probe now, you can see, in other words, discriminate between the brightness of these low contrast lesions and the brightness of the background more easily while the probe is moving than if I hold it stationary. Now they start to sort of get a little bit more difficult to distinguish from the background. So that's the first technique, is image persistence in improving your low contrast discrimination. It seems pretty crude, but in the hands of a skilled person, you can adjust the trade-offs there. The trade-offs, of course, are that the speckle reduction is being blurred, the speckle is being blurred and therefore reduced while the probe is in motion, but of course so too are real tissue resolvable structures. So the detail and the information you want to pull out of the image is being blurred a little bit as well. But if you're clever, you can use that interactively by scanning, quickly surveying, and allowing your eye to be drawn to low contrast details that are made more visible by the speckle reduction due to the persistence. And then if you think you've spotted something, then hold the probe still and allow the probe to follow respiratory motion, or ask the patient to hold their breath, and then start to see the finer detail which you might see for the resolvable structure that doesn't need the speckle reduction once you've found it with the persistence switched on. And you can keep pausing and moving and pausing and moving as you're scanning around using that technique interactively. The next simplest type of speckle reduction to use is something actually on this scanner. It is actually called speckle reduction. Now what that does, it analyzes in each small region of the image the local texture pattern, and it's analyzing that pattern to decide whether the statistics of that pattern are similar to speckle or not, because speckle has very particular statistical properties. Those statistical properties are a characteristic of the scanner, not so much of the tissue. Of course, each region, when we're imaging anatomy, in this phantom, it's almost all speckle, because the phantom is not built with any resolvable structure apart from these inclusions and the wire targets. But in a real breast, you have a continuous mixture of partly resolvable structure, fully resolvable structure, and then the much finer detail right down to the cellular level, unresolvable structure. And it's the unresolvable structure that provides the speckle component. Ideally, one would like to smooth out that part and leave only the resolved structure. That ideal is never achievable, but we can get some way towards it with a method called adaptive speckle reduction. And that is what's implemented here. So, if I demonstrate that, and the demonstration will show what the computer is doing in terms of manipulating the image. The computer uses the local statistical assessment of the texture of the image to make a judgment of whether that texture is probably speckle or probably real structure. And if it's probably speckle, it'll smooth in that region. And if it's probably structure, it will leave the image alone. And it grades the effect between those two extremes. But clearly it's going to make the wrong decision some of the time and over-smooth some real structure or under-smooth some speckle. Let's switch this into the maximum level to be able to demonstrate the effect, and immediately you see the image has changed, dramatically so. I'll just switch that out back into no speckle reduction, and then what you see when we switch in the speckle reduction is some of the detail in the background speckle gets preserved and the other is smoothed. And this is overdoing it, and the effect of overdoing it is to sort of apparently create anatomical structure where there is none. Now we have an image here. Let's see if I can zoom in to show you some of this. You can see a very different texture pattern to the background, and this is very much artifactual as a result of the behavior of this filter. So not good in this particular phantom because it's a bit distracting. Although under some circumstances, and I'm wondering whether I can demonstrate that with an image of my neck, let's try it. Under some circumstances, it can produce an interesting result in that the brightness settings are not good for my thyroid, but let's zoom out. It's not a nice image to look at. Let's switch out the speckle reduction again, and we'll turn the gain down because for my thyroid that's far too bright. And we'll turn the dynamic range up a bit. You can see the thyroid gland displayed with quite a bit of speckle inside it. And speckle is dominating the appearance of a lot of the image. And I'll switch the speckle reduction back in. And it's smoothing the thyroid gland, but drawing our attention to the vascular structure present within the fine detailed vasculature. So even though the image is not one that I particularly like, it is drawing the eye's attention to some interesting detail. And similarly in the muscles on the neck, it's doing the same. So you can see the effect of that. So a better setting is a compromise. And we can see that if I go back to this image, I need to just reduce the dynamic range down to about 69 again. Brightness down for this phantom. Maybe, oh, that's probably okay. And let's tone down the adaptive speckle reduction down to maybe 2, something like that. Which in combination with persistence, once I start moving, now we're starting to see really quite a nice image, but it's going to get better. You can see these boundaries nicely. We can see the low contrast lesions quite nicely when we're moving. Okay, the next type of speckle reduction I want to switch in is angle compounding. Now, what's that doing? It's taking the ultrasound beam that normally comes out straight ahead, and instead it's steering it sideways. And first of all, it'll steer it that way and make an image, and then there, and then straight ahead, and then that way, and then that way. And I don't know how many images this particular scanner combines, but it could be anything up to maybe 6, and anything down to maybe 3, and I think there's some control over how many different angles it will combine. I mean, it's not as steep an angle as I am showing you with my hand. It's only a small amount, but what happens is as you steer the beam to look at a particular tissue volume from a different direction, that changes the speckle pattern, but hopefully does not change the tissue structure that you want to see. So the changed speckle pattern, when you combine the two images by averaging, will tend to blur the speckle but keep the real structure. Life isn't quite that simple, it never is it? But it does it to a certain extent. And there is a penalty. You do get a little bit of blurring. The effects of that can be due to things like speed of sound variation in different paths, or maybe tissue motion because this has a frame rate penalty, and other effects. But that blurring isn't very strong, and it's often very worthwhile switching this technique of angle compounding. Probably the place where you'll see the blurring most is in some of the diagnostic signs for breast tumours. For example, the edge shadow that you get on carcinomas. And that might be just slightly less clear than it would be without the compounding. Although with an aperture this size, for this sort of narrow transducer, the amount of compounding that you can get is not that great. And so the penalties are not that great either. And it's often worth using. If you're really concerned, you can switch compounding on and off to see whether the diagnostic signs that you're looking for are improved or made worse by having compounding on and off. Let's have a look, and I might in a moment switch back to the matrix array probe. I was deliberately using this linear probe for the moment to illustrate the speckle because it has a nice sort of strong speckle display. So at the moment we've got persistence switched in, we've got adaptive speckle reduction switched in at a moderate level. Let's switch in the angle compounding. On this scanner it's called cross beam. So here it is. That's set to a low value. I'll just switch that off again. You can see the speckle clearly. I'm holding the transducer still. In fact, what I will do is I'll switch off the speckle reduction so that the speckle is even more obvious, and switch in compounding, and you can see it has quite a big effect. If I switch in the level 2 speckle reduction, you can see that the image is starting to get really quite a nice image now with all of the speckle reduction techniques in. That crossbeam or angle compounding is set at a low level. If I increase the level, there's a low, there's a medium, and there's a high. I presume that's the maximum on this scanner. Nope, there's another one that says max. So there's no super max, so we'll stay at max. And you can see now how beautifully even the lowest contrast lesions are displayed. If I'm moving as well, they're very clear indeed compared to what we started. You can rewind the video yourself to make that comparison. I'm not going to switch all the controls out all over again because that would take some time. So the effect of that maximum angle compounding might be easier to see if I zoom in again. Let's have a look. And if I go to the low contrast lesion, we can there's 2 low contrast lesions there, a negative and a positive, and we can see how clearly they're displayed. Then I switch out the compounding and I'll switch it back in, and you can see the effect of that. You can also see one other effect, and that the boundaries are a little more clearly displayed. That might be true. I wasn't watching, but we can switch out and have a look at that mimicked cyst there to see if that's also true. I'll switch out the compounding. It's not so obvious on the cyst, but here I feel I can definitely see the edges of this lesion and probably that lesion better when I've switched the compounding in. I hope you agree, particularly when we're moving. Okay, that's all of the speckle reduction and compounding and types of things switched in, and that's the scanner kind of running at maximum image quality. There is one other image improvement function that I want to illustrate to you, and that is tissue harmonic imaging. On this scanner it's called coded harmonic imaging. Essentially what that does is it uses nonlinear propagation of ultrasound, which generates harmonics of the sound wave as the sound wave propagates in order to improve the quality of the images. Well, I say improve. Again, there are trade-offs. You get some improvements, but there may be penalties on some occasions. Whether there are substantial improvements depends on how much aberration there is. In a phantom like this, there's very little aberration from fat, non-fat layers, for example. And you may not see very much change in the image properties when we switch from fundamental mode imaging to harmonic mode imaging. But we'll try it. We'll illustrate some of the points with the phantom. So this is the image still with our 9L probe. I might well switch to the matrix 1.5D array probe to see what effect coded harmonic imaging has on the different probe. In any case, it's been a while since we went back to that probe to have a look at the quality of the images from it. So at the moment, we're still set with persistence switched in, with speckle reduction switched in, and with angle compounding switched in. All of the facilities to improve the image. The frame averaging at the moment is not excessive. As we said, we'd set it to about 2. Yep, I've got it on 3 at the moment. Okay, tissue harmonic imaging. So this is the fundamental mode image. I will now switch in harmonic imaging. The scanner resets itself, and that's the sort of image that we get. It's different, that's certainly true. It's doing something more than typical tissue harmonic imaging, and I think that's because this scanner uses what's called coded harmonic pulses. That coding technique is actually using ultrasound pulses that are sent out, that are coded and can be decoded on the way back, as well as using the harmonics. That might give us a bit of penetration advantage over what's normally termed simple tissue harmonic imaging, which tends to suffer slightly worse penetration than fundamental mode imaging. And the reason for that is that the harmonics that the scanner's tuning into don't penetrate the tissue so well. The coded harmonic images here are showing a different background texture to what we see with the fundamental B mode. But I've noticed immediately that the point targets, the wire targets, are sharpening up. Let's switch that out again. And you can see how blurred the deeper one is compared to the, and then I'll switch it back in. Yep, to my eyes anyway, they're definitely sharpening up, particularly at depth. So we seem to be getting improved lateral resolution from the harmonic imaging. It's a characteristic of harmonic imaging that you sometimes see a slightly worse resolution in the axial direction, simply because to tune into the harmonics you need to sort of generate them with slightly longer narrow bandwidth pulses. But I don't see much evidence of that penalty here. Occasionally, well, maybe I do. Actually, if anything, I see an improvement in the axial resolution in the harmonic mode. So this looks like a good mode to use on this particular scanner. But beware, the changes in the image texture will change the anatomical detail that you can see in the image. So you may, as with angle compounding or speckle reduction, you may wish to switch it in, switch it out at the beginning of an examination to decide which image is best for that breast or that pathology. It's hard to say in advance for sure that harmonic imaging should be used in this type of breast versus another type of breast, but you could argue that breasts that contain a lot of fat, non-fat interfaces might suffer, particularly close to the probe, aberration and need harmonic imaging improvement more than others. Difficult to say. Reverberation is another thing that harmonic imaging helps with, and I have no substantial reverberation in the phantom. Reverberation can occur between fat and muscle, for example, and the reverberation gives the effect of echoes deeper to the structures that the reverberation is occurring in, reverberation being the sound bouncing backwards and forwards within a layer of fat and muscle, for example, or other layers, that then comes back at a time that makes that echo appear at a deeper structure where it should not be, and therefore will act as what we call clutter in interpreting the image of those deeper structures. That's probably best illustrated on my thyroid, and I can show you some carotid, well, it's not the thyroid, but my neck. I can show you some carotid artery reverberation. Maybe I'll switch out the frame averaging. And we'll go back to a single focus number so we're getting a reasonable frame rate. And put the focal zone at about the depth of my thyroid. Set the depth so that we can see that with reasonable field of view and resolution, and I'll just change the brightness setting. And I'm going to switch out the harmonic imaging. Now notice all of the fill-in in the carotid artery here. And now I switch in the harmonic imaging. In fact, if I do a Valsalva maneuver, you can see all the clutter inside my jugular vein as well. And I'll switch in the harmonic imaging. And it's cleaned it up quite a lot. It's substantially reduced the reverberation, it's cleaned up the muscle appearance, and it's cleaned up the carotid artery and the jugular vein appearance. I think quite a lot. So it's doing a lot of good things to this image. But it has changed the nature of the image as well. So it is worth making a decision as to whether you prefer it or not. Many scanners will switch on. They will just power up in harmonic mode. Because in general the images are better. Okay. Let's just switch to the other transducer and see whether I can say anything different about that one. So I have switched the scanner into running with the matrix array, 1.5D array, and I'll scan that bit of my neck again. And immediately you can see just how much better this probe is than the other one. Beautiful detail. And at the moment it's in fundamental mode. And you can see, again, we've got some echo fill-in both the carotid artery and the jugular vein. You can see pretty good fine detail in the muscle layer there. A fine speckle pattern in the thyroid. An interesting bit of physics, though, that I can't resist pointing out while we've got this image on the screen, is the second thyroid here. Of course, that's just a mirror of this thyroid because all of the sound is being reflected at the trachea. And so we see this mirror artifact image present in there. Let's go back to the point that I'm supposed to be illustrating, and that is if we switch in the compound harmonic imaging, again how it cleans up the image and makes a much sort of cleaner echo structure, particularly in the two blood vessels there. I can increase the gain. Sometimes when you switch harmonic imaging in, the gain does need to be adjusted a little bit. And it's quite interesting to have a look at the really anterior regions, looking in that muscle structure, to see how that changes when we switch harmonic in and out. So that's what it looks like with harmonic imaging. And that's fundamental mode imaging. And oddly enough, I think for looking at the muscle structure, I have a feeling that there's things I can see there that may have been a bit more difficult to see with the harmonic. Back on the phantom, let's have a look. And that needs a bit more gel. We really don't have a problem with fill-in the cyst. That's because there's almost no reverberation occurring in anterior structures here on the phantom. It just doesn't happen in these phantoms. So it's difficult to illustrate the difference between the harmonic. Let's go to a slightly greater depth setting. Let's see what we get there. These point targets are so beautifully displayed with this probe that I was searching in the wrong place for the phantom for the moment. And this is with contrast harmonic switched in. What we do see is a slightly different penetration effect. I'll switch it out again. We're penetrating to sort of, in the background gel, we're running out of signal at about 2.5 centimeters there. And in the fundamental mode, we're getting an extra centimeter or so of penetration. So that is consistent with what I was saying earlier, that the harmonics tend to be absorbed more rapidly, and even the coding technique that this scanner is using doesn't really greatly overcome that penalty. So it is a reason why you might want to try both modes and decide for that particular patient which mode is giving you the right information. Okay, the sort of closing part of this demo is to illustrate a few other functions on the scanner that are additional. One of those are what I would call, to some extent, post-processing functions, such as rejection controls or suppression controls, as they're sometimes called. These are sometimes included for cosmetic appearances of the image to clean them up. Rejection or suppression would have the effect of rejecting or suppressing the low-level echoes. Ideally, you would want, if you're setting that, to set that so that you are suppressing the noise in the image and not displaying it. I actually prefer to see the noise. It's visible in its twinkling and its characteristics as noise. And if I see the noise, I know that I'm not missing any information. If I switch in some suppression or rejection, there is the potential to miss some information. It's perhaps partially illustrated on this phantom with one of these inclusions that are in the phantom that are the very low level negative contrast regions that have some weak echoes present. And if I switch in rejection on this image, you can see the effect of that on the image appearance as there. Two things happen. One is I appeared immediately to get not such good penetration. I'll switch it back out again, and we see that. But also you see a suppression of the low-level echoes within this inclusion. Those are real echoes, they're not noise, and yet they're being suppressed. Now, there's potential there that if you use suppression or rejection, a potential for not seeing low-level echoes within a cyst, for example, and then making the mistake. If it were not a cyst, you might classify it as a cyst. So that could be low-level echoes in a solid lesion or elsewhere that you might misclassify. If I switch that out, you can see that come back again. It's an illustration of the potential for misinformation. It may make the image look as if it's better, but there's the potential for losing information. So I would tend to not use controls like rejection or suppression. So another post-processing function that can be adjusted is the grey map. That's the function that controls the way in which the echo strength, the echo amplitudes, are translated to grayscale values as a brightness on the display. It's similar to the dynamic range, but it acts independently of the dynamic range. So you can set your dynamic range control, but you can independently set the grey map. Now, the grey map is post-processing. It's taking the output of the nonlinear amplifier that did the dynamic range compression to the dynamic range level that you set previously, and it further modifies the grey levels on the display. It's best illustrated, rather than me talking about it, just to illustrate the effect of it. So I'll press the function that allows you to change the grey map. The default grey map that we're using here, you can see, is grey map F. They're all coded on this scanner by letters of the alphabet, and as I move from one map setting to the other, you can see a change in the image grayscale appearance, and indeed the corresponding grayscale wedge, as we call it, at the side of the image is changing as well. For some reason it's jumped out of that mode and frozen the image, so I'll just go back and get into setting that again. And you can see how grey map J on this scanner is a very sort of high dynamic range map, a bit washed out. You can select one that you prefer. Generally speaking, I can't imagine you using that control very much, and it's most likely the default setting is the one that you want, which on this scanner I think was G. So I'll just cancel that, come out of it, and I would use the default setting of the grey map, and I would set the dynamic range to my preferred setting. Similar to that, you can adjust a color map. On the scanner it's called a tint map or colorize. What that is doing is taking the input echo amplitudes and assigning to each one a different color, just in the same way as the grey map assigns a different grey shade to that echo amplitude. And if I demonstrate that, you can see that here we've got a sort of sepia toned image, and we can make that a more blue toned, another type of sepia tone, magenta, and so on. Again, it's unlikely that you would find a lot of uses for this. One possible use for it is that the lowest level echoes, if you have undesirable ambient lighting, as we have here for filming this video, then the very smallest amplitude echoes might not be easily seen on the screen. Particularly maybe if you've misset the dynamic range and you've got the dynamic range too low, then the contrast on the display would be perhaps a bit excessive. By using a color tint map, the lowest level echoes now become a slightly different color and perhaps can be discriminated more easily from the background black level. I think that is of a dubious benefit, and again, just like the color map, I think most of the time you're best off setting the room to the correct lighting conditions, subdued light, and working with the standard color map in grey rather than using a tint. So that's all of the main functions demonstrated. Just two things to finish the demo. One is you will often find controls such as trapezoid scanning, or on this one it's called virtual convex. Essentially what that does is it uses the steering capability that we mentioned earlier that provides angle compounding or cross beam, but now just uses it to steer sideways at the edge of the field of view to give you a kind of trapezoid scan even from a linear array. And that allows you to have a slightly wider field of view at depth. I'll just switch that in. Takes a moment for the computer to reset itself, and then you can immediately see how we've got this wider field of view at depth. We're seeing much more of the phantom deep down, and indeed if we had used the lower frequency probe, we'd be able to see that having the effect even at much greater depth settings. So that's that function. The last thing I want to say is going back to the gain and the acoustic power output. And it's just to remind you of the acoustic safety considerations, always to check the MI and the TI, mechanical index and thermal index, which are displayed at the top right-hand corner. And bear that in mind when using the ultrasound scanner. It's not tremendously important for the breast, of course, but nevertheless it's a matter of sort of policy. It's worth not using any more acoustic power output than you need to in order to obtain the image for the diagnosis you need to make. Most scanners will come set, so when you power them up, they will switch on with a fairly high acoustic power output. And if I just show you the effect of reducing the acoustic power, that's just on this image. At the moment it's on 90%. I can increase it to 100%. The image changes very little in its properties, and we can bring that down around, well, 30-40% is getting a little bit low. We're down at 50% output. I can increase the gain to compensate slightly for that. And at 60% output, the image really isn't that much different from the 90% output. So the opportunity there is to achieve just the same sort of image quality that you need to achieve, and yet putting much less sound into the patient, giving a much lower sort of exposure to ultrasound. Okay, there are two points that I've not been able to demonstrate easily with this scanner. One was the auto-optimize that I mentioned right at the beginning of the demo, and another is speed of sound optimization. And for those two, I would need to switch to a different scanner to show you those. To finish off the demonstration, we have moved to a different scanner and a different room, and that's because I would like to complete the process by showing the auto-optimize function that I mentioned to you earlier, as well as speed of sound optimization. And both were mentioned in the physics lecture, so it's good to show you with the hands-on demo as well. This particular scanner has both functions, allowing me to show you how they operate. I'm using here, just for completeness to describe it, a 15L4 probe, so it's very wide band and allows frequencies between 4 and 15 megahertz to be used. It's a breast imaging probe that this particular manufacturer sells. And we can see here the same phantom that I'm using as I did with the other scanner. The image isn't too bad as it is at the moment. If I switch into measure TGC, then I can deliberately, if you like, misset the TGC. And I'm going to sort of give it some kind of crazy settings that you can see with a dark band in the middle, and then exit that. And then I'm going to press what is the automatic optimize button. Do that right now. And the scanner analyzes the image data and sets the TGC automatically to provide a reasonably homogeneous image with depth. But as you can see, it's not absolutely perfect, and we can probably do a slightly better job ourselves. And again, to do that, I do what I recommended earlier. I will turn the dynamic range down, and I will turn the B mode gain down so that it emphasizes the small brightness variations. Go back into TGC, and I should be able to just improve those dark patches and bright patches a little bit so that it is slightly better set, and that's probably as much as I'd want to do. As you can see, that's a better job, I think, than the Auto Optimize did. I can now turn the dynamic range back up and the B mode brightness back up, and now we have a very uniform image with depth. Another thing the Auto Optimize button will often do on many scanners is adjust the dynamic range. It'll adjust the grey level map for the sort of preset, the breast imaging or other imaging preset that you've chosen. And as I said earlier, that won't necessarily know the lighting conditions that you're working in, or the diagnostic information that you want to extract in the part of the body you're scanning. It's a good starting point though, and if you're in a busy clinic, then by all means rely on it. It will produce a reasonable image for scanning with. So the very last thing to demonstrate, which I am able to do on this scanner, is the speed of sound optimization. The reason that is important is that it affects resolution, and speed of sound varies in different tissues. And if you get the speed of sound wrong, the scanner assuming the wrong speed of sound, then it'll upset focusing, it'll upset beam steering. That influences compounding, because beam steering relies on the correct knowledge of speed of sound to be able to adjust the delay profile across the array elements. And if the steering is not correct, then the registration between different compounding components will be wrong. So the effect of compounding will be to degrade spatial resolution quite a lot. Focusing also requires that the scanner know that the speed of sound is what it is in the material, otherwise it can't adjust the delay profile for making the transmit focus or even the dynamic receive focus correctly. So this particular scanner I've set to have a very large depth of field. It should be in focus over the whole range of depths that I'm indicating there, from shallow depths down to beyond 3 centimeters. We can see in this phantom that down here the point targets are displayed with a very poor point spread function there, very wide laterally. The focus is not too bad up here, and part of this is, I think, because I've misset the speed of sound. It's actually set to 1420 meters per second. In this phantom, it's almost certain that the phantom's been set up to mimic tissues and to have a speed of sound of around 1560, 1580 meters per second. But that's not necessarily breast tissue. So let's change the speed of sound. It's currently 1420 meters per second. You won't be able to see that on the display. It's on part of the scanner's knobs, which the camera is not on. But I'll change it. It's now gone to 1480 meters per second. Already you can see the effect on the image, and I will change the depth setting so that we can see a bit deeper. Switch back to 1420. You can see how wide the lateral point response function is here, very poor. 1420. 1480, already sharpened up a lot. And this is now 1540, suddenly very sharp. And now 1600, getting blurred again. And 1660, very blurred again. There's another thing you'll notice is the vertical scale of the image changes. This is because all of our vertical scaling, our axis scaling of the image, is dependent on speed of sound. It's the go and return time that tells us where an echo structure is positioned along the beam axis, and we need to know the speed of sound for that as well. So if I do that again, it's currently set on 1660. I'll reduce it to 1600. You can see the positions of these targets moving closer to the transducer. There's 1540. That's the point at which we felt we had the maximum lateral resolution. And now 1480 and 1420. And this is probably the most blurred result of the lot. And also it's the one where these targets are closest to the transducer. So that's the other thing that it influences. If you're measuring dimensions of structures, then having an accurate knowledge of the speed of sound helps that measurement accuracy with the ultrasound calipers in the axial direction. So, in summary, speed of sound is important for lots of things: caliper measurement accuracy, image scaling, focusing, beam steering, compounding, and getting it right. And for this phantom, it looks as if the speed of sound is what I expect it to be, in the mid-1500s, and that gives us the best quality image that you can see here. Different tissues have different sound speeds, but the tissue that has the biggest difference in sound speed from all other tissues is fat, and it has a very low sound speed. So it's likely that if you're looking at a breast that is very parenchymal, very glandular, then you might want to use a slightly higher sound speed, 1540 maybe. But if it's a very fatty breast, then you might want to use a lower sound speed. But the nice thing is that if your scanner allows you to adjust the sound speed, then you can simply use the image quality, the image sharpness, to judge what it should be, because simply adjusting the sound speed on the scanner to find the one that gives you the best image quality is the way to do it. Some scanners have different types of controls. I believe one scanner has a thing called fat imaging, and switch that in for imaging fatty breasts. I know of another scanner that has a sound speed optimize button, which works much the same way as the automatic TGC optimize did on this scanner. When you press on that scanner the optimize button, it will go through all of its possible sound speed settings, and just like an autofocus camera, will judge the image quality, and it will choose the sound speed where the image quality is the best, the image is sharpest. So that can be particularly convenient to use. Either way, even if it's manual, it doesn't take very long to do it. So even if you're in a busy clinic, it's probably worth doing. Well, thank you for listening. I hope that demonstration, even though with the switch between scanners, was useful and complemented the physics basic principles lecture, as I hope it would be.